All right, so welcome everybody to the second last forum session of the year. Very, very pleased indeed to have Dr. David Keely here today to talk about the possibilities of expanding Medicare and basically creating some kind of decent healthcare system rather than some kind of insurance industry that we are basically under at the moment. Dr. Keely is a public health policy educator and a physician epidemiologist. He's originally from Philadelphia with a BA degree from Swarthmore, his medical doctorate from Wake Forest. He did his family residency here in Charleston at MUSC, and subsequently did a Master of Public Health at UNC Chapel Hill. He practiced family medicine for more than 30 years, and he's worked in public health policy and administrative positions. And I am going to make Dr. Keely a co-host in just a second so he can share his screen. Let me see if I can remember how to do that. And there he is. And I will now welcome Dr. Keely and pass things over to you.
Excellent. Thank you for that nice introduction. And I'm going to share my screen here. Can everybody see that?
Yes, it's coming up.
Coming up. Okay. I see. I was trying to move it so you may need to minimize to the thumbnail video so that you can see the entire slide. That's an option for everybody. And as you can see, what I want to try to really energetically at this point is recruit you folks to start with the idea that we can't afford not to adopt a universal healthcare system in our country. And, I'm going to make the case that in three areas, equity, affordability, and universality, that this is just something that has got to be done sooner rather than later. It's going to take some programmatic improvements to Medicare. If any of you are currently on Medicare, there are some improvements that can be made. We would, most importantly, adopt a new nonprofit single-payer financing system. And in doing that, we would be able to have maintain high-quality health care, maximize patient accessibility, which of course is a problem, as we will talk about later, and assure that this is a sustainable system in healthcare by eliminating, the profit-driven parts of our current system. When we think about just our country and the people, to have a system that really is based on earning higher returns for stakeholders and stockholders, that puts the emphasis in the wrong place. And as a physician, that's a very frustrating part of our system. And then, of course, the current problem with drug prices and the overwhelming control that the big pharmaceutical industries have. So when we talk about 2020 is kind of hard to talk about because of all the effects of the pandemic, but in 2019, we we're at almost 20% of our gross domestic product in our healthcare expenditures, almost $4 trillion. And just 10 years ago, we were around between $2 and $2.5 trillion. So we've had just tremendous increases in our expenditures. So now let's talk about what's equitable. What are the key points there? And we have a really important natural experiment that occurred with the COVID-19, or has occurred with the COVID-19 pandemic, where we really saw among underinsured and uninsured people in our country just very statistically significant higher levels of morbidity and mortality. In the underinsured, we know that the states where Medicaid at the state level was expanded, those folks who were in the coverage gap, which I'll show you a little bit later, they were found to be in have more advanced chronic illness features, but once they were covered under the expanded Medicaid, there were measurable savings at the state level in the Medicaid system. That's one thing we've been trying to get across to our legislators here in South Carolina. And then the COVID-19 pandemic exposed significant, again, statistically significant barriers to people of color in accessing care. And again, where there were chronic health conditions that were more advanced, those people of color did not fare well in battling COVID-19. Public option, our country has, talked about where to go forward, and the public option is going to fail here because what we know is from the private insurance industry, and the Medicare Advantage programs, they are all about squeezing out sicker members so that they can then, reap higher profits. So we have no reason to believe that the private insurance industry won't do the same thing with the public option. You may have heard in February of this year about the Lancet Commission. It basically studied the 4 years under the Trump administration and looked at different things happening in our country. And one of the big things that I'll show you a graph in just a minute was that G7 countries, we see that one of the big indicators of how a healthcare system is working or is not is life expectancy. And actually, I'll just go ahead to that slide now. Here you see the G7, and the lines in the graph are in order. So Japan is at the top in life expectancy, and this runs from 1960 to 2018. So where's the United States? We're trailing for most of that entire time period, but even worse has been over the past 30 years. When did Canada implement its single-payer system? It was in the 1970s. And so here we see Canada is the dark blue line. And, you can see that through the 1970s, the United States and Canada were close, but that Canada has really improved in life expectancy compared to the United States. And then the Lancet Commission, one of its major findings was that in this country, to have an equitable system, we're going to have campaign finance reform. There's too much money and too much influence in Washington, D.C. with the hospital industry, the pharmaceutical industry, and the private insurance industry. So let's talk about affordable. Many of you may know someone who's what we call in job lock because of our employment linked access to health insurance. People are feeling like they can't move to a new job because they will not have the same kind of health care coverage. It may not be affordable, and it's just that they also, until we had some protection on pre-existing conditions, people were stuck in a job just because of their health insurance situation. And then many of you may be aware of how employers have struggled to manage the increase in healthcare insurance costs, and that has resulted in lack of salary or pay rate increases, lack of hiring new full-time employees. Employers are going to part-time so they don't have to cover health insurance. So so it's eroding benefits, and even lack of access comes in here. The public option again will fail here, and has failed already because of the high premiums and/or high deductibles that have priced out many of the enrollees in the Affordable Care Act system. And so we have a proposal currently from the Biden administration that's talking about a public option, but because of what's happened with the Affordable Care Act, we know that affordability will be an issue. High drug prices, goodness gracious. Many of you may have sought to buy medications in the international market. It's just astounding the difference that people are paying here in the United States compared to countries like Canada and England. Well, Canada really is the best comparison. If we eliminate those high drug prices through federal government price negotiation, that's a real positive. So I got a plus sign there. And then we can also say, and I'll show you some numbers in a little bit, we know that with a universal system that is nonprofit, we will have 90% of Americans would actually pay less and get much more comprehensive health care, including more preventive care. And so there's clear healthcare savings, which I'll show you. And the most recent study, there have been 20 plus studies over the past 20 years of the single payer nonprofit universal system with Medicare for all. And we know that well, based on the most recent evaluation team at Yale University, we would not spend more, we would actually save $450 billion. I mentioned the coverage gap, and this is, if you just focus on the red area, that is the area where people can be, they can be childless adults, they can be in low-income households, or they can be aged, blind, or disabled. And based on the federal poverty level, they are not eligible for the Affordable Care Act. And that has been a concern in South Carolina, particularly where we have about 200,000 eligibles who are unable to afford buying into the Affordable Care Act and who are denied access to Medicaid. So then let's talk universal. We've talked about equitable, we've talked about affordable, universal. The saying that I like to use is everybody in, nobody out. And also that healthcare, we have to, as a society here in the United States, we have to come to realize that it's a public good. And it should be in the same category as our fire protection, police protection, and our K through 12 education. You know, back in the mid 1800s, our country decided that to have a strong, stable democracy, we had to have an educated electorate. And so, you know, over the subsequent half century, we implemented public education. So healthcare is clearly, to me, a public good, and we need to acknowledge it as such. So that leads us to, well, if everybody is in, nobody's out, that means that a person can see any physician, be treated at any hospital, anywhere in the U.S., and there would be no more restrictive networks. Some of you may be familiar with, you know, Medicare Advantage is lots of advertisements in the media, and one of the ways that they do save money is by negotiating tight contracts with providers and thereby forming these restrictive networks. And look at this, I mean, the pandemic, we know from the pandemic how fragile the mental health is in so many households. And, you know, we would have mental health care coverage that would be more comprehensive. We would have dental care. We know that a lot of physiologic maladies in the presence of dental disease, gum disease, particularly, can worsen a lot of conditions and even precipitate acute events. Eye care, hearing services, you know, particularly as our population ages, and then long-term care. You know, we have medical bankruptcies. We have, you know, from acute conditions, but then long-term care can really make a difference in the quality of life in the later years. And so to have a guarantee of long-term care, that's part of what we're talking about this morning. So just looking at the Medicare system, you're in control. I personally have a Medicare supplement, and I'm still in control. I'm not tied to any networks. And Medicare, so I'll show you, has very low overhead, only about 2 to 3% administrative costs compared to the private insurers where they had to be reined in by the Affordable Care Act to not be higher than 20% administrative cost. And as I'll show you, with Medicare in our country, we can show that people live longer and are staying healthier. So my bottom line is that the nonprofit single payer national health program is not only affordable, but it's the only affordable option, and I'll show you why. So we have, and this slide actually is set up to go in stages, so it's not going to do that. But what the way we're doing this on that Zoom, but you can see along the bottom line different large private health insurers, and here's the range of insurance overhead, and that you would think would be something that would get the attention of most Americans, with Medicare Parts A and B, as I said, between 2 and 3%. And look at the increase in cost over the past, well, this shows 10 years from 2008 to 2018, and the spending per enrollee for Medicare running at 21.5% increase compared to 52.6% increase in those covered with commercial health insurance. These are 2019 figures. And here's what I was referring to, the healthy Americans. If you look back over the time course of a person's life, the USA rank in the world for, compared to 17 peer countries, we rank between 15th and 17th in terms of health indicators. But look what happens when Medicare kicks in at age 65. Our both men and women, we increase to, by 10 years out, we're at about 13, 11 in terms of rank, and by the time we're in the 80s, we are among the healthier of when compared to 17 peer countries. So this is kind of a felt to be good evidence that Medicare does mean healthier. And as I mentioned, when you look at a number of studies over the past 15 to 20 years, the savings would fund, and of course, it depends on the assumptions that you make. And so a lot of these, oops, not wanting to switch here. But I'm going to show you a slide which has the savings and the cost. Just a second here, if my computer will cooperate. And what we know from, oh, see, we jumped ahead. There we go. Go back. There we go. So the red bars show for the various studies, and these studies date back, as I said, 15 to 20 years. We've been trying to make this case for single payer Medicare for all. But you can see the cost of increased utilization. We know that if you provide healthcare affordable coverage to everybody, that there's going to be some increase in utilization. So that is calculated. And then for each study, the green bar shows the savings. And you can see that in most every case, the savings bar is larger than the cost of increased utilization, leading to a net savings over the course of these many studies in the range of 10 to 15%, that particularly at this end of the graph. So it just makes economic sense. And then I mentioned the Yale study, which is the most recent one, taking into account both the cost of coverage expansion and the savings that would be achieved through the Medicare for All Act. We calculate that a single payer universal healthcare system is likely to lead to a 13% saving in national healthcare expenditure, equivalent to more than $450 billion annually. The entire system could be funded with less financial outlay than is incurred by employers and households paying for healthcare in the premiums that are combined with existing government allocations. This shift to single-payer healthcare would provide the greatest relief to lower-income households. And as I mentioned, 90% of Americans would realize a decrease. The average cost for a family of 4 in terms of total healthcare outlay would be out of pocket, plus what they're paying in insurance premiums and deductibles. For a family of 4 in the U.S. is $24,000 a year. And but the projections based on the assumptions that you have to look at for these various studies, we would realize $450 billion savings, which if you say we're spending almost $4 trillion, that's about 12% savings. So, but even more important, every day in the United States, we have the equivalent of an airliner crashing and all the people dying. And excuse me, I gotta get rid of that. We have every day in the United States, we have the equivalent of a medium-sized airliner crashing and everybody dying. And what country would continue to allow that to happen? There would be all sorts of efforts to make changes in the airline industry to prevent that. Well, we have that going on in our healthcare system. We have in a given year, we could save more than 68,000 lives and a lot of quality life years with a affordable, universal, and equitable healthcare system. So the elegantly simple part of Medicare for All is that all of the what this slide is supposed to show you is that there's a big gap between the people and the healthcare providers that is filled with cost. And so what this slide is intended to show is that improved and expanded Medicare for all will actually bridge those costs, that cost divide, and get healthcare into the hands of the people that need it. And affordable, you would think that, as I said, healthcare is, in our country, is seen as a for-profit commodity when you come down to it. And what we need to do is look at it as a public good, and that it's an important part of us being a healthy and productive society. How can you educate yourself more? Physicians for a National Health Program has an excellent website, and I would recommend, I would ask you if what I've said so far piques your further interest in learning more. Go to pnhp.org and take advantage of the resources that are there. There's great comparison, one-page summary documents, and particularly when we're looking at legislation right now in the U.S. Congress, the House of Representatives bill number 1976 is the Single-Payer Improved and Expanded Medicare for All bill, and I would encourage you to familiarize yourself with the bill at the PNHP website, and then we will want to be in contact with our elected representatives in the House to ask them to support the bill. And if you have continued questions, or if you're finding that neighbors, colleagues are interested in learning more and asking you questions that you're not sure about, the PNHP website has great resources in all of these areas. One label that politicians or particularly partisan politicians, they of course, you're hearing the word socialism and as a label that's supposed to be a turnoff. Well, in the healthcare realm, socialized medicine is the turnoff term that they're trying to use. And this is not socialized medicine. This is a publicly funded but privately delivered system of care. That's important. The decisions and questions about who makes the rules on a national health program like we're proposing, there would be regional oversight bodies that would include healthcare professionals and business professionals and public policy professionals that would oversee decision making about the system. So that's something that people would have to understand, because there are some regional differences in the way that care has evolved in our country, it makes sense to have a regional oversight body. And then physician support. What are physicians saying about this? Over the course of the last 2 to 3 years, the American Medical Association, which has a definite bias towards the specialty areas of medicine, has even come out, and we have over 55% of members of the American Medical Association, which again is predominantly specialists at this point, saying that they would support a single payer, universal, accessible, affordable system. So if you're really want to get into the mode of supporting this effort, becoming a member of Physicians for National Health Program organization, it is open to everyone. There are different levels of membership that are open to everybody, and we in South Carolina are trying to grow our membership and have an active team that's advocating for this change in our healthcare system. We call ourselves Healthcare for All South Carolina. We have a web presence that is linked to the PNHP website, and I am the current president, and we are partnering with organizations across the state. We are partnering with statewide League of Women Voters organization. We're partnering with the statewide NAACP organization, partnering with statewide Our Revolution South Carolina organization. And we are particularly at this point focusing on Medicaid in South Carolina and expanding it to all members that are eligible, to all citizens who are eligible under the Affordable Care Act. And so I think your congregation has recently sponsored an important educational effort on this. And so we wanted you to know that Healthcare for All South Carolina is very much sees expanding Medicaid in South Carolina under the Affordable Care Act as a stepping stone, a necessary one, it seems, in the political scheme of things to ultimately achieve a universal single payer publicly funded, privately delivered health care in South Carolina.
Well, thank you, Dr. Keely. We got to 10:40 and we got a bunch of questions in the chat. Can I just go to the chat and ask people to ask those questions as quickly as they can so we can hear your responses to them?
Yes, sir. And
all right, so Libby, you're first up if you want to go with your question. Libby Smith, you'll have to unmute yourself.
Unmute, yeah.
You said early on that the Medicaid Advantage plans were pushing out people that were basically heavy users. How do they do that?
Well, the way that they do that is the premiums that they are looking, to not have to charge. They work with the, once you have an expensive illness, they look to start charging premiums, and that's and then of course with the aspect of their networks, they make it in a separate effort, make it more difficult for physicians to participate, and they end up dropping out, and then that leaves people frustrated, and so they look to an alternative, and they ultimately find out that if they disenroll with Medicare Advantage and move over to a Medicare Supplement, that then their health condition becomes a pre-existing condition.
Oh, wow. I didn't think that
Yes.
was even illegal.
Yeah,
That's
and
amazing.
that's really a very troubling surprise that that people.
One other quick one is looking at other countries that have single payer. Most of them, Canada, Australia, England, have the ability for folks who want a better level of service, essentially, to buy some private insurance, to get private rooms and quicker service. Would you advocate us planning around those kind of options for people?
I know that there's going to be in any free society, there's going to be people who are going to want to buy their way into
Right.
services, and so there's not any good way to say no. What we would concentrate all our efforts on is making sure that things like wait lists are understood and don't enter into the quality, the health quality of a person's life. Most of the disinformation that's been promoted about waiting lists in countries like Canada has to do with elective procedures.
Exactly. Yeah. Okay, thank you.
Thanks, Libby. Can we move on to Diane Boyer and then Diane Narkunis and then Ren? And we've got about sort of 5 minutes, so be as quick as you can, please. Diane Boyer first.
Yes, Dr. Keely, my question has to do with something that you said earlier about the solution to this problem is going to require campaign finance reform. And I was totally convinced of the need for universal health care before all the facts you presented, but the achievement of the goals that you presented are, I think, almost entirely political. And does your organization have some sort of organized and coherent plan to achieve this political support? It seems like an almost overwhelming problem to me.
Well, Physicians for a National Health Program is nonpartisan, and they're very aware of the organization is called a Partnership for America's Healthcare Future, which is basically the coalition of the private health industry, big players. And so actually Physicians for National Health Program, through efforts of students in training, have convinced the American Medical Association to withdraw from the Partnership for Healthcare, America's Healthcare Future. So that is that's one thing that has effectively happened. As far as we're all going to have to be in support of and asking candidates whether they are taking money from big pharma or big in health health insurers. And as voters, we have to show our show our action at the voting booth. But I think the answer to your question is mainly it's the Partnership for America's Healthcare Future, where we have a disinformation campaign that is being promoted at the state level around the country to try to overcome some of the messaging that the Partnership for America's Healthcare Future is putting out.
Thank you.
Diane Narkunis, please.
So I think you have a great program. I think you could get a lot of support nationwide. We need to educate the American public regarding this effort. Do you have the resources to do that? What sort of efforts are you making in that direction?
Well, Healthcare for All South Carolina, we have our 4 regions. We have a growing group in the upstate in the Greenville area. We have a fairly new group in the PD, Horry County coastal area. And then we have a group here in Charleston, with you in Charleston, that's based at MUSC, that's primarily it's spearheaded by students in training, students for a national health program. And then in the Columbia area, we have several physicians who are, helping to spearhead. What we're finding is that if we can get to organizations that have county level presence, that's why the League of Women Voters is we feel is so important, that we can then partner and do grassroots education, as you say, which is just extremely important, particularly in the run-up to the 2022 elections.
Can we take one final question from Ren Manning, please? Ren, you're on about Vermont.
Okay, yeah, wasn't there an experiment in Vermont of something like the universal health care program?
The Vermont experiment, actually what they found was that the economies of scale, the population in Vermont was not large enough for the cost savings to be realized. And when really the final determination came to the governor to decide on whether to move forward with a single payer system in Vermont, the governor voted no, and it had to do with the tax. The public funding was just not the base for public funding. The population base wasn't big enough for him to politically take that step.
Dr. Keely, we've got to just after 10 till 10, and we have to get 10 till 11, beg pardon. We have to get ready to go off to the actual worship service. So thank you very much indeed for this. Somebody's put on the chat, can we put this on YouTube? And that is, of course, where we do put the recordings, is on the church's YouTube channel. So I will hope that all of our CAJM members, for instance, will actually take a look at it and go to some of those websites you pointed out to us, so that they are well armed with the information that you've provided, because this has been really, really informative and extremely valuable to us all. So thank you very much indeed.
Yeah. Well, thank you for the opportunity. And you can contact Simon if you have further questions that you'd like me to respond to. Just send them to Simon and he'll forward them to me. I'll be glad to work on them. Thank you.
That's great. And next week is our last session in this season's program of UU Forums. It's going to be by Glenn Smith of the Post and Courier, talking about their recent series of articles on Uncovered, looking at basically local South Carolina corruption and inefficiencies and things like that. And the Post and Courier is actually doing really very good work on that and promoting the value of local newspapers. And I think that should be a really, really interesting session. So that's on D-Day, June the 6th, next week. But thank you very much, Dr. Keely. And I see he's put the address, their email address, and you've seen all the website addresses as well. So see you folks next week. Thank you very much indeed, Dr. Keely.
Thank you all. Stay healthy.
You too.
It's great.